Hi, I'm Zaid. Me and my co-presenter Anusha are going to be presenting Gender Differences in Medical Evaluations, Evidence from Randomly Assigned Doctors by Marika Cabral and Marcus Dillander. This is a paper that essentially looks at whether or not there is a change in treatment or an evaluation of medical needs based on whether or not your doctor is the same gender as you. The paper uses data from Texas, which has an insurance program for workers injured on the job, which covers all of the medical expenses that come with injury, and sometimes it also covers additional cash benefits. And whether or not you are eligible for these cash benefits will depend on the evaluation of your treating doctor, the one who's assigned to manage your injury. However, insurers and claimants can appeal this treating doctor's evaluation of whether or not whether or not you're as impaired as the doctor, for example, suggests you are, or whatever. And so at those moments of conflict, Texas randomly assigns independent designated doctors to evaluate your case. And this random assignment is going to be the main driver of the variation through which we will investigate the research question later on. So the research question in this paper is, does gender match between patients and independent doctors impact medical evaluations and subsequent social insurance benefits? Spoiler alert, it does. We see that gender match seems to improve outcomes for female claimants while having no effect on male claimants. We see that the magnitude is significant. Gender match nearly closed the entire gender gap in outcomes seen between male and female claimants. And finally, we look at survey evidence, which could possibly hint towards different mechanisms for why this occurs, and policy counterfactuals can be investigated for the impact on gender gap in evaluated disability. So literature review. There's a lot of research that has already been done in gender gap in healthcare, specifically healthcare quality and whether or not benefit receipt. And just a list of some of the research that's already been done: female patients are less likely to receive aggressive treatments. Female patients are less likely to receive treatment to alleviate pain, even if they're reporting the same amount of pain. They're more likely to be told that their pain is emotionally driven rather than arising from physical sources, and they're less likely to receive Social Security disability insurance. So even though this evidence is widespread, there's little understanding in the literature of what drives the gender differences and what kinds of interventions may be able to improve these disparities. This paper is able to narrow down a potential cause of it, that male doctors are treating male and female patients differently, female patients worse than male patients, and hence is able to evaluate different recommendations for how to improve this. Speaking of concordance, which is to have the same gender or the same race between the patient and the doctor, there's already evidence of this being good for health outcomes. We've seen that it helps reduce hospital mortality in other cases, and we've seen that Black men are more likely to take up preventative care when counseled by Black doctors rather than white doctors. This paper focuses on whether or not this concordance at the earliest stages of the healthcare interactions, at the checkup phase, at the medical evaluation phase, if there's an effect at that stage as well. And we see that there is. Other contributions of this paper include evidence of gender homophily, which we've already seen in the literature, where patients choose doctors of the same gender as them. This has more evidence of that in the data and the survey. We also see there's literature on the impact of female authority figures in the outcomes of women, but usually in the literature, these kinds of effects are very muddled and mixed because there's lots of different channels through which female authority figures may be able to influence the outcomes of women. Because in our data, it's a very narrow mandate. The doctor only sees whether or not you are eligible for cash benefits. The number of plausible mechanisms by which they are able to influence is limited. So whatever effect we see, we can assign to a particular mechanism much more easily. In this case, we assign it to the importance of gender match, where authority figures are charged with evaluating women. Finally, the contributions of looking into the gatekeeper model. A lot of public funds are distributed at the discretion of gatekeepers. For example, if you apply for bankruptcy, judges will be the determinant of whether you get it, doctors in this case of workers' compensations, or hearing officers for unemployment benefits. This paper highlights that depending on the type of gatekeeper and what kind of gatekeeper and the supply of gatekeepers that you have, there can be distributional effects on the recipients of the public money in the end. Background and data. So to focus more on the Texas case that this paper uses, The workers' compensation insurance is a state-regulated insurance system that provides covered employees with cash and medical benefits for work-related injuries and illnesses. All of the medical expenses for the injury are covered. Whether or not you get the cash benefits, as I said, is something that will be determined by your treating doctor, who is chosen by the patient. So the patient chooses who's going to treat them, and that treating doctor will evaluate whether or not you're eligible for getting these cash benefits. Cash benefits are of two types: temporary income benefits and permanent impairment benefits. Temporary income benefits are meant to replace wages forgone due to on-the-job injury. So you're not able to work for a week or two. This is supposed to alleviate that problem. And they're based on the prior weekly wage that you were already earning. This ends when either of three things happens. Either employee goes back to work, employee has reached maximum medical improvement, so they aren't able to improve anymore by staying in the hospital, for example, or maximum duration reached. So there's a 2-year maximum on how long you can receive temporary income benefits. Usually it's one of the first two that trigger. Permanent impairment benefits are meant for people who, for example, have lost an arm because of their work. This is not just you're losing out on weeks of work, you're also losing out on a huge quality of life. So this is meant to compensate permanent impairment due to on-the-job injury, is based on prior weekly wage and the permanent impairment rating. So a rating that the treating doctor assigns on how impaired are you. It starts when either the maximum medical improvement has been reached, but you're still impaired, or whether your 2 years have been exhausted, but you're still impaired. Independent medical evaluations occur when there's a disagreement between the insurer or the patient on the evaluation of the treating doctor. Nearly always, it's the insurer who has a disagreement. So that's when the designator doctor comes in. They need to complete training and testing and recertification. They conduct a small number of exams, and as a result, the vast majority of their practice is still with their standard practice. They're randomly assigned by the state at the county level, depending on availability and credentials. They cannot have a conflict of interest with patient or insurer, so they can't have worked for the insurer before or treated the patient before. And their only duty is to evaluate whether maximum medical improvement has been reached and the degree of permanent impairment, if any. So this is a flowchart of the entire process. We see workplace injury occurs, they choose the treating doctor, medical expenses are paid, the doctor evaluates the MMI and permanent impairment status, temporary income is discontinued and permanent impairment benefit is potentially given. There's a contestation of the evaluation. A designated doctor is assigned for the independent medical evaluation. If they evaluate you to have no impairment, then it's thrown out. If you're still impaired, it's either because you are permanently impaired, in which case they assign a permanent impairment rating, or they say that you're still healing, so your MMI has not been reached, and so they either set a date for when your MMI will be reached or do not set a date, depending on how they do it. The doctor that will be deciding on which date your MMI is reached will differ. The data comes from independent medical evaluations carried out in Texas from 2005 to 2017. Before 2013, this was done manually, so which doctor you were assigned was done by a human. Now it's an automated system, so as a result, the focus is on evaluations from 2013 to 2017. The benefits received is focused on the 12 months after the exam date. So how much benefit do you receive as a result of the evaluation after the exam date? Some cases are dropped because they had missing gender information, but this is a minority of the cases, and the final sample has around 71,000 exams performed by around 1,500 different doctors. Instead of looking at the actual benefits received by the patients, because that's dependent on prior weekly wage, so it will differ between different patients, they create a variable called normalized additional benefits, which just looks at the mean inflation adjusted temporary income benefits or the mean inflation adjusted permanent impairment benefits, whatever those values are, and then they multiply it with how long were you on each of those types of benefits. So depending on how long of the next year you spent on temporary income will be multiplied with the average temporary income benefit, etc. So everybody is now divorced from their particular prior weekly wage, and so you have benefits independent of it. We have some summary statistics on the claimants. The main thing to notice for this is that female claimants are not identical to male claimants. You consistently have like different age and different first-day medical spending, etc. Like they're not exactly identical. And we have summary statistics for the doctors. And the main thing to notice from here is that we don't have a lot of information on the characteristics and demographics of the doctor beyond their gender. Empirical strategy for how the research question will be investigated. They use this equation above as their model, and I indexes the claimant, C indexes the county, all of that. The main thing here is that theta is a vector of fixed effects for a claimant's county by doctor's credentials, and XICP is the set of additional controls included in some specifications. In the baseline models, it's just the year of claimant's injury and the year of exams. So I've created a table here of like what is the expectation based on this model of a male claimant and male doctor's outcomes is theta CP, and so on and so forth, right? So we can have interpretations for what beta 1, beta 2, and beta 3 are, which will go in the next slide. The dependent variable YICP will have two forms in this paper. First, it'll be indicator variable for being assessed as having continued disability. So either you have permanent disability or you haven't reached maximum medical improvement, so you're continuing. So it's mentally a measure of whether or not they're in favor of the patient, right? And the second one is normalized additional benefits. So that's the one, that's a new variable that I just discussed a little while ago. There's amount of benefits that you get based on the evaluation that you receive. So interpretations for beta 1. Beta 1 is the one that's on the female claimant. It's a coefficient on female claimant, and it contextualizes the estimates for the rest of the coefficients because it captures the gender gap in benefit receipt among claimants evaluated by male doctors. So this is the main difference between how male doctors treat male patients versus female patients. Beta 2 is the difference in outcomes for male patients if they're compared to if they get a male doctor or a female doctor. Beta 3 is the coefficient of interest. It's what is the effect of a gender match, essentially, like getting a female patient with a female doctor and male patient with a male doctor and stuff. So this is the gender match coefficient that we care most about. Next, we have a balance test for whether or not you can predict the claimant's features and characteristics based on female doctor, whether they received a female doctor. We expect this to be very small coefficients and also statistically insignificant because female doctors were randomly assigned. And that is exactly what we see. We see that the female claimant is still statistically significant because but that's just capturing the fact that female claimants are different from male claimants across these features, as we showed when we looked at the summary statistics. Now I'll hand over to Anusha to discuss the results of this paper.
Hi, I'm Anusha, and I'll be talking about the results of the empirical strategy that Zai just discussed. So over here, we have column 4, which shows the effect on benefit received. And columns 1, 2, and 3 basically have the dependent variable as an indicator variable equal to 1 if the designated doctor assigns claimant as having continued disability, whereas columns 4, 5, and 6 basically show the additional benefits that the claimants receive. Columns 2 and 5, they include doctor fixed effects, as we can note over here, and this basically focuses on the within doctor differences in the assessments from female and male claimants. And in 3 and 6, they restrict the sample to female claimants only, and this shows more evidence that female claimants are more likely to be assessed as being impaired when seen by a female doctor rather than a male doctor. So now for the following presentation, we'll just focus on columns 1 and 4 because these are the results of the main regression. Over here, we'll first focus on the female claimant, which is also known as the gender gap variable. And we note that the coefficient 0.031 on female claimant basically shows us that female claimants are 3.1 percentage points less likely than male claimants to be assessed as having a continued disability when both are assessed by male doctors. And now if we move on to the coefficient on female doctor, we note that this just shows us the difference in the likelihood that male claimants are assessed as having continued impairment when examined by a female doctor rather than a male doctor. And we note that this number is really small and statistically insignificant. So this basically shows that the gender of the assigned doctor does not really impact whether male claimants are evaluated as disabled or not. And if we now move on to the interaction term between female doctor and female claimant, this is also known as the gender match variable. And this suggests that compared to differences among their male patient counterparts, female patients are randomly assigned a female doctor rather than a male doctor. There are 3.0 percentage points more likely to be evaluated as having continued disability. And now if we look at this ratio between the gender match and the gender gap, we note that this is an almost near complete closure of a gender gap. And this basically is huge because we're saying that female patients, when they're getting a female doctor, the gender gap that we notice when they don't get a female doctor, it's basically getting close by 100%. So next, we're going to look at the regressions from 4 to 6, just focusing on 4. And this is from the result of the Poisson regression on the additional cash benefits. And here again, over here, we note on the interaction term between female doctor and female claimants that female patients randomly assigned to a female doctor rather than a male doctor are 8.5% more likely to receive more cash benefits on average, which is an almost $478 evaluated at the mean of 5,627. And this is, again, we note that really significant. And again, if we note the ratio between these two, there's almost a 61% closure, not 100% like we saw before in column 1, but even 61% gender gap closure. And this is, again, really huge. So if we note the variable on, again, the female doctor, we really note that there is no gender match effect for like the male patients. In fact, the point estimate really suggests that male patients may receive more subsequent benefits when assigned to a female doctor rather than a male doctor. But again, this effect is like statistically insignificant and really indistinguishable from 0. So next, we note that there is really no objective measure of appropriate level of evaluated disability or efficient level of cash benefits. We cannot really determine whether the female doctors are too generous or the male doctors are just too strict in their evaluations of female patients. So we basically, in this setting, what authors do is they try to know that if we add for extra variables control for the observables on the claimants, what may really happen. And while doing so, they note that the female claimant, again, this coefficient of them is constantly negative and is statistically significant for all of when we include all variables. And again, this number is not really different, this magnitude. So it's, again, doesn't really show much of a difference when we control for all the observables. And again, when we note that when we include richer variables, it is, again, there's really little impact on the magnitude for this interaction term over here. Again, confirming the robustness of their main findings that we found in column 1. And again, if you look at the cash benefits, same there, it's negative and statistically significant. And again, over here for the interaction term, it's positive and statistically significant. So now they ask, what happens to gender gap if you look at the entire sample of worker insurance claimants in Texas? So the primary analysis basically focused on disputed claims, but randomly assigned evaluating doctors. But the authors have like a greater administrative data on a wider set of claims from Texas from 2013 to 2017. And they basically want to look at the gender gap in this area. And they also want to see what happens to gender homophily in the selection of doctors when patients have a choice. So we note that on average, female claimants, again, are 5.5 percentage points less likely to receive benefits than male claimants. And again, when they brought in the gender homophily, we basically expect to see this gender homophily because if females expect worse outcomes from male doctors, then they should select away from male doctors when they're really given a choice to select their treating doctor. So the question they asked was, do female patients select female treating doctors more often than male patients select female treating doctors? And again, we see that there is a 2.3 percentage points more likely, female patients are 2.3 percentage points more likely to select a female treating doctor relative to a male patient selecting a female treating doctor, which is noted over here. And again, this is statistically significant. So next they say that is gender match really only particular relevant amongst like some particular subgroups of female patients? Because if this is the case, then this basically points to potential mechanisms behind the importance of gender match. And over here we have this figure which considers how the effect of female claimants being assigned to female doctors differs by the baseline claimant characteristics, which are distinguished by demographics, injury characteristics, and prior claim experience. And panel A basically just displays the estimates for an indicator of an additional benefits after the exam. And panel B, again, just uses the normalized additional cash benefits. And these are capped horizontal bars with 95% confidence intervals. So though the estimates, if you note, are not across the subgroups are not really statistically distinguishable from one another, we notice that there is a pattern in point estimates that suggests that female gender match effects may be more pronounced amongst some claimants, such as lower earnings, or female treating doctors have more severe injuries, did not really initiate a designated doctor exam, or work in a less dangerous industry. And I think the most striking thing to note over here is that the gender match effect estimates are positive within all subgroups considered, and they're statistically distinguishable from zero for many of the subgroups. And I think these findings really suggest that the patient-doctor gender match has a universal impact on outcomes for female patients. So now they ask, why do we really, one would really wonder, why do we really have this gender gap? And some possible reasons that the authors point towards are that there's doctor discrimination against patients of opposite gender, there's doctor favoritism towards patients with same gender, or patients might behave differently or communicate more or different information that may impact their evaluation. For example, a female meeting a female doctor will be more comfortable talking about the problems she has compared to like a male doctor. So they find further evidence of these mechanisms through a survey. And basically, the aim of the survey was to firstly assess the differences between male and female patient experiences in the broader healthcare system, and to learn how and why doctors' gender is associated with differential healthcare experiences. And the second aim was to understand whether patients exhibit preferences for their own gender providers, or whether the intensity of these preferences varies across men and women. So the sample was conducted, the sample for this survey was around 1,500 adults between 30 to 64 years of age. And they basically limited the sample to like male and female. So they have roughly the same amount of male and female respondents. And this was conducted in May 2021. So the first set of questions over here that they really asked were whether the respondents have ever experienced any negative interactions with the healthcare provider. And I think the main takeaways over here are basically that women are more likely than men to report negative experience. For example, if you note over here, 39.3% women and only 34.0% men report having experience where a doctor talked them down or didn't really treat them with respect or dignity. And this is a greater than 5 percentage point difference. And if you control for the unobservables, it's like 8.7 percentage points. And again, there's another example over here where we know that there's a 4.2 percentage points. Women are more likely to say that male doctors made them feel uncomfortable while discussing their concerns. And this is again 5.9 when we control for all the unobservables. So now we notice the second part of the questions, which was basically how the doctor's gender influences the likelihood of having a positive interaction. And women, again, were much more likely than men to report an own gender doctor would be more likely to treat them with respect or understand their concerns better, believe them, provide the necessary testing and treatments, and ask appropriate questions instead of making assumptions. We note that over here with one example. And I think to further emphasize this intensity of preferences, they basically conduct this survey where they give these hypothetical choices to people. So they were basically told to choose between giving like out-of-pocket costs for their own gender versus just giving it for like the opposite gender. And there were noted as like female doctors $30 out of pocket, male doctors $5 out of pocket, and then female doctors $10, and then it went on to like 5 over here where the opposite gender was like $30. So panel A basically displays the estimates based on like initial randomly assigned choice set, while panel B displays estimates based on a full set of hypothetical choice questions that were asked. So I think the more important thing to note in the results over here is that whenever it is cheaper to see an own gender provider, nearly all women select an own gender provider. And in contrast, a lower share of men would select to see their own gender provider. And these gender gaps are statistically distinguishable from zero, and they're robust to controlling for respondents' characteristics. So for the panel B, we again see like similar patterns, but they're just more precisely estimated because they rely on the responses of like full set of hypothetical choice questions. In general, I think the survey really suggests that the women relative to men are more often, their concerns and symptoms are discounted by doctors. And this asymmetry of responses between men and women supports the plausibility of the main findings of this entire paper, that the doctor gender is an important factor in evaluation of female patients, more so than the evaluation of male patients. Further, the survey evidence suggests that the differences in doctor behavior are likely an important driver of the main findings and highlight several possible ways male doctors relative to their female counterparts may be discounting the concerns of and symptoms of these female patients. And it also reveals gender differences in the intensity of preferences for own gender providers, with women being willing to pay more to see their own gender provider more often than men. And again, these gender differences in preferences to see their own gender providers may reflect gender differences in patient expectations of having positive interactions with own gender versus opposite genders. So now, with all these questions about the gender gap, the authors really ask, what can we do with this gender gap? What can we do in terms of policy? And they suggest two policies. One is that we can increase the share of female doctors, and the other is increasing the gender homophily. So they estimate this using this regression where the gender gap, conditional on observables, is a function of the overall share of the treating doctors who are female and the degree of homophily in the market. And more broadly, they characterize the trade-offs between policies that may increase the gender diversity amongst doctors and the policies that increase sorting of patients to the same gender doctors. Over here, we have this image, figure 5, which basically illustrates the level curves of this regression. And they characterize the combinations of gender composition in the doctor workforce and the gender homophily patient-doctor matches that would result in a given value of a gender gap. So the combination of conditions in this status quo is represented by X over here in this figure, which is basically a gender gap of 16.5%. Namely, females are 16.5% less likely to receive cash benefits than males with same observables. And the share of treating doctors who are female, which is around 28.4%, and the degree of relative gender homophily, which is 1.058. So female patients select female doctors at 1.058 times the rate that the male patients select female doctors. And I think there are at least two important qualitative properties worth noting of this entire image. First, that the level curves are negatively sloped, and this indicates that the given reduction in the gender gap can be achieved by trading off increases in the share of doctors who are female and increases in gender and in relative gender homophily. And second, that the level curves are convex relative to the origin. This convexity reflects the fact that the inputs that are the share of the doctors who are female and the relative gender homophily are complementary in reducing the gender gap. So one way we could interpret this entire image would be like, suppose if you're interested in understanding the change in conditions needed to reduce the gender gap from 16.5 to 15%, this reduction in gender gap would be accomplished by increasing the share of doctors. So we could increase it to like 34.5%, holding homophily constant at 1.058. Alternatively, it could be accomplished by increasing the homophily to 1.5 and holding the share of female doctors fixed at 28.4%. So now we will have the critiques and all, which will be discussed by Syed.
Last of all, we will look into critiques of this paper. Full disclosure, we think this is a very good paper. And so the critiques are a bit difficult to pin down, but we will give it our best shot. First, we look at alternative explanations for this. So it could be that due to other provider or patient characteristics associated with gender, we have all these effects. So there's an omitted variable bias. The paper tests this hypothesis in two ways. First, it looks into, do male and female doctors treat patients differently by other observed patient characteristics? And so they just replace the female claimant indicator variable with other claimant characteristics and see if it still works just as well at predicting the results. And it shows that none of the other potential patient characteristics that they use, income being less than the median, age being older, prior doctor being female, etc., none of them have a significant result. The second thing that the test is, do other doctor characteristics explain differential assessments of female claimants by male and female doctors? So is it some other doctor characteristics that's causing this? So the way they do this is they regress an indicator variable for doctors assessing claimants as having continued impairment on injury year fixed effects, exam year fixed effects, doctor fixed effects, doctor X female claimant fixed effects for each of the 917 doctors which have at least 10 exams. Then they regress the doctor X female claimant fixed effects of each of these doctors, which is a doctor-specific measure of generosity towards female patients relative to male patients on the doctor characteristics that we do have. And when they do that, they see all the other characteristics that we do have are also not significant, except for being female. However, as I mentioned earlier, the doctor characteristics we do have is quite limited, so this isn't really a full rebuttal to the potential point. So there could be, as I alluded, there might be unobserved characteristics that of patients or doctors that were not observed by the researchers that can explain these effects. And we've considered one that seems very plausible. It could be that there's a different level of experience when dealing with female patients. Because of gender homophily, female patients will likely choose female doctors. So female doctors are more likely to have experience dealing with female patients. And it could be that this differential experience is explaining the greater rates of believing and diagnosing female patients, since they just have a better ability to understand the symptoms of female patients by having worked with them for so long. So it might be because of the gender homophily that we see this kind of result, which would have troubling implications for some of the policy proposals that this paper has, because if it wants to use gender homophily or more gender matching to close the gap, it might be a long-term problem where male doctors just do not have enough experience down the line. There's also external validity critiques, because the results are only from the US and specifically only from Texas. It's unclear whether it'll hold for other parts of countries or for other countries. Even if the general result holds that gender match helps close gender gap, it's unclear how strong the effect is. In this data, we see that it closes it completely, but in other places, it might not be like that. And there are multiple reasons this might not hold. Texas might be particularly aggressive with respect to gender gap. Medical evaluations may not be independent elsewhere, or industry-specific insurance may cause distribution of gender across industries to affect gender gap. So if there's industry-specific insurance, then if an industry has more women than men, that might affect the gender gap because you're capturing the insurance policy of the industries. Next is a critique of the measure that they use for cash benefit. They use this normalized additional benefits, which I discussed earlier, which is a function of the length of time of receiving a certain type of a benefit and the mean of the weekly benefits associated with that benefit type. However, designated doctors are able to directly affect the benefits that are received, because if the designated doctor evaluates the claimant as being permanently impaired, then they will have to assign a permanent impairment rating, which factors into what level of permanent impairment benefit that they do get. So it's not just like them deciding that you have permanent impairment and then you get the average permanent impairment benefit. So it may be that female doctors have a lower threshold for acknowledging female permanent impairment compared to male doctors. So they acknowledge disability more often, but they give low impairment ratings and hence low actualized benefits. The normalized additional benefit measure would overstate the lost benefit from not having a gender match then, because there's actually very low permanent impairment benefits, but this measure ends up exaggerating it. That ends our critique and the presentation for our paper. Thank you for the attention. I'm sure that we did go a bit over time though.